We'll just let everyone come in. Hi everyone, my name's Dr. Sam Mayer. I'm a paediatric allergist, immunologist based in Melbourne. It's my pleasure to chair this session with two fantastic speakers. I'll go through sort of an outline of what we want to say, but let me just introduce the first speaker who'll come on after me. Professor Jo Douglas. Most of you shouldn't need an introduction, but I'll introduce her anyway. She's a consultant allergist immunologist holding the James Stewart Chair of Medicine at the University of Melbourne. When you Google that, you work out that's actually a big deal. That's hard to get. And serving as an Executive Director of Research at the Royal Melbourne Hospital. She's published more papers than I can imagine, over 150, spanning lots of stuff: allergy, respiratory allergy, immunodeficiency. I had the pleasure of being the treasurer when she was ASCIA president. And if you want to see someone at top of their game how to chair something, go see Jo. That was like masterclass stuff, seeing like 20 immunologists and allergists arguing about God knows what, like cats. And then somehow she managed to wrangle us, get us back on track and get us to dinner on time. So that's what I remember of Jo, like unreal. So Jo's, we're going to talk about obviously allergic disease, allergic respiratory disease, really and please put your questions in the app as you know, but there's certain questions that you might have, like, and I struggle with sometimes, even in my older age, like, am I choosing the right allergen? Should I do it by should I do it by subcutaneous? Should I do it by sublingual? Am I really achieving remission for these patients, or are they going to come back and see me? Are there any sort of markers I should be using, or should I just do a skin test? Thanks very much. That's what you got. See you later. And so without further ado, here is Jo.
Thanks so much, Sam, and everyone. Thanks for such a kind introduction. It does feel sometimes like herding cats, but I'm always hungry by dinner time, so we'll always finish on time. And I always promise people when I start a meeting, we'll finish on time. And I generally achieve it, and today is no different. So I'm really looking forward to sharing with you discussion about remission and biomarkers in respiratory allergy. There are my declarations. I count myself incredibly fortunate to have practiced medicine at this time when treatments have changed so much for respiratory allergies. I'm old enough to remember those poor people who came through the door with terrible asthma, terrible rhinitis, bent over from steroids, osteopenia. You know, it really was terrible. And now we can give people a biologic and often look for remission. And I think the whole goals of treatment, which we can now also achieve with immunotherapy, are really starting to change the way we look at allergy treatments. Because if we go back historically, we treat to failure. We treat to collect those at the end who don't respond to our cumulative ladder of drugs. But in this time and this age, I think we need to go better and look for really remitting in disease. And I want to spend the first few minutes of my talk talking about what disease remission means in respiratory allergic disease and in asthma, and see how we can apply that with the promise that's held by allergen immunotherapy. Disease remission means that we really need to think about modifying or managing the underlying pathways of disease. It does mean we've got to do some personalised medicine and actually phenotype what actually is the person suffering from. We need great treatments that can actually induce an anti-inflammatory remission or a remission of disease. And then we need drugs or opportunities to actually sustain either a cure or actually remission of symptoms. So in the asthma space, remission of adult asthma has been described in the Global Initiative for Asthma Guidelines. And in particular, it's come into attention since the introduction of biologics. And an asthma remission is defined as having no asthma symptoms, no exacerbations, no use of oral corticosteroids for asthma flares, and stable or improving lung function over the time of treatment. This is quite extraordinary, but those of us who treat people with biologics for asthma know that we can go from having terribly severe asthma to having what looks the closest thing to a cure. Of course, it doesn't always mean they've got to be on a biologic, and there's many people become remitted with asthma. Perhaps some of them grow out of it, but beyond that, also drugs including inhaled corticosteroids, the other pharmacotherapies and allergen immunotherapy can also induce these remission. But just reviewing the evidence with relation to biologics, this is from the Australian mepolizumab and omalizumab registry, which has just over 400 patients accrued who received either mepo or omalizumab for severe asthma, according to the treatment guidelines that we have on the PBS. And they were looking for remission, particularly lack of asthma attacks, lack of use of oral corticosteroids, and of course symptom control. And if we look in the left panel at mepolizumab, if you want to look here at individuals who had an asthma control score of less than 0.75, which is by consensus well-controlled asthma, you can see that about 23% of people had well-controlled asthma and about 18% had well-controlled asthma with stable lung function that was maintained during treatment. So in other words, there is a proportion of people, about 20% on mepolizumab, perhaps a little less with OMA in these studies, although certainly with OMA in these studies, about 12 to 13%, that actually achieved symptom remission from asthma. I should point out that the OMA patients were recruited first, and I think many of them ended up switching drugs over time because these were the ones before we had anti-eosinophil agents. So it is interesting. But the point is we can achieve remission with asthma with biologics. And so the concept of remission in respiratory and allergy treatment can also be applied to allergen immunotherapy because it's currently the only treatment intervention that not only can cause disease remission or improvement whilst the treatment's being administered, but also the opportunity for long-term benefit once the treatment has been withdrawn or completed. So we can certainly have, and the Global Initiative for Asthma includes allergen immunotherapy in its guidelines as treatment for asthma, including severe asthma controlled by biologics and for patients seeking long-term benefits when standard therapies are insufficient. And the point about GINA and indeed the other global initiatives in inducing asthma or remission from allergic disease is that we're no longer just seeking symptom control, but thinking about how we can induce remission. And I probably don't have to tell this audience that the trajectory of inducing the clinical and biological remissions that occurs with allergen immunotherapy can occur through the induction of regulatory mechanisms, the induction of antibody types that actually favour a tolerant response to antigen exposure, reduction of IgE levels, and the expression of or skewing or diversion of the immune response to a more Th1 from a Th2 phenotype that can be sustained in an off-treatment remission that we can document. So I want to just now, having discussed with you a little bit what remission might look like in allergic disease, let's see where that gets us to with regard to allergen immunotherapy. So we do have evidence for remission. This is evidence of disease improvement where the treatment has been withdrawn for house dust mite tablets, for grass pollen tablets, and for cedar pollen tablets. I'm not going to talk about them anymore, but I am going to talk about dust mite and grass pollen, given that they're the two major common allergens in Australia. And in our practice of the individuals who we see who are atopic, about 70% are sensitised to dust mite and about 50% to grass pollen, and there's obviously very substantial overlap in that. So the first evidence that, the other point is that native allergen tablets have good evidence for remission. So the first evidence this might come is from this trial, which is now a decade old, from Bergman, that looked at 1 year of 300 and 500 IR dust mite tablet immunotherapy and showed that there was a symptom response. This is an adjusted symptom score by medication use in year 1. And then treatment was ceased at the end of year 1 and the patients were continued to be observed through year 2. And you can see that there is a remission of symptoms that occurs, or a reduction of symptoms that occurs, despite the withdrawal of treatment. Now, a post hoc analysis of this data looking at those who had high symptoms in the first instance as opposed to those who had low or medium symptoms shows about a 30% reduction that's persisting in year 2 off treatment. And the reason that's really important is that perhaps a good clinical reminder to us that we should be choosing those individuals with quite high symptom burdens, often the ones who have the most chance of symptom reduction. And I should also remind you that this is placebo controlled, so we know this is against placebo. And that's really important since so much of the data and post hoc data or post marketing data is not compared to placebo, and we know there's a big placebo effect that often compromises allergen immunotherapy trials. So this is important for 1 year of treatment, and indeed this has been noticed in meta-analysis that for this house dust mite formulation, 1 year of treatment might be enough, where the usual recommendations are for 2 to 3 or 3 years of immunotherapy to produce a sustained physiological and immunological response. So, do we actually have evidence for longer-term remission for allergen immunotherapy? And this is a study that was published last year in The Lancet Regional Health, which is data from a huge German database of health utilisation data. So it's a real-world study. And what it did was take 10 years of insurance data from over nearly 6 million people from 2007 to 2017. In that time, it had 115,000 descriptions of allergic rhinitis and 47,000 prescriptions of allergen immunotherapy. It matched the individuals over time to look at their concomitant use of asthma, in this case, but also rhinitis treatment, but I've only shown you here the asthma treatment. The data is very similar for the rhinitis symptom treatment and showed. And the other point was that they had to have just had 2 prescriptions for allergen immunotherapy, which would have been at maximum or a minimum of a year's treatment overall. And it was agnostic to the mode of allergen, although 80% was skit and only 20% slit, and also agnostic to the allergen that was actually administered, dominantly dust mite, but also grass pollens and birch, of course, tree pollens are so important in Europe. But what this showed was a significant reduction as far out as year 9 in the utilisation of the odds ratio for asthma exacerbations. And this data is mirrored with regard to asthma and rhinitis medications with, if you like, an off-treatment benefit that was very durable in this large real-world study of over 45,000 individuals. So this is quite remarkable data that attests to the significant benefit of allergen immunotherapy in producing a durable remission of symptoms once treatment has been completed that in fact is quite long-lived, longer-lived than many of the placebo-controlled studies have gone on, although I guess Steve Durham's original study was 3 and 7 years in randomisation. So really amazing, really interesting data to look at the possible benefits. And this is increasingly being recognised. So having said that AIT has the propensity or the possibility of causing durable remission in both asthma and rhinitis, let's switch now to our local scenarios. And I probably don't have to tell this audience that house dust mite allergy is our major perennial allergen in Australia and gives, whilst I think it has a bit of a flare in autumn in symptoms, the symptoms are perennial. And we're also uniquely, especially in southeast Australia, have a huge springtime burden of grass pollen allergy, which induces significant hay fever. And Australia has globally very high rates of allergic rhinitis, approaching over 20%. So that's 1 in 5 people suffering from allergic rhinitis. And the main symptom season for grass pollen allergy is October to December. And I often have my Sydney colleagues telling me, oh yeah, but we get it worse than you because we get a longer season because of the subtropical grasses that are so important in Sydney. And we do grow subtropical grasses where I come from, Melbourne, but obviously they're a bigger burden further north. But interestingly, if you look at symptoms, and this is the pollen count on high pollen days and also being read by DNA of the pollen counts from Sydney, what you can see is that the main pollen that is detected between the 1st of October to the end of January to the end of December is temperate grass pollen, so ryegrass pollen or other families from the temperate grass family pollen. And in fact, the Bermuda or subtropical grasses are really barely present at all. in this time and perhaps peak a little later, if at all. So I think it's an important question to realise that if we're looking at hay fever between October to December, anywhere on the eastern and southern seaboard, we're really looking at the temperate grass pollen allergens as being the major allergen that has been noted. Now, of course, it's not just hay fever, and I really like this study that Jeremy Silver published in PLOS One a few years ago. And what this did was look at aggregated data from 25 years of Victorian Emergency Department presentations for asthma over the extent of a year. And this is in all age groups, January to December. And what you can see is that there is a peak of a flux, a seasonal flux, that's a little bit gender specific, but there is a peak in February, March, which is particularly prominent in 0 to 19-year-olds, which is probably the school kids going back to school and getting viruses. And that's certainly been noted in a comparable Northern European return to school virus epidemics of asthma. There's a midwinter epidemic, which you can see particularly in the 65-year-old plus group, which would suggest it's viruses, influenza, RSV, other winter-borne viruses. And then we have this important seasonal October, November, December increase, almost fourfold from here, of asthma presentations in the springtime related to grass pollen. Well, presumably related to grass pollen. And interestingly, they found that predictors of high asthma admission days within this time were related to pollen concentrations in the previous 3 days, not just the previous 1 day, the weather events in particular, the wind speed and precipitation, and of course the presence of airborne particles, because after all, grass pollen's just another pollutant. So we all know about thunderstorm asthma, and certainly I've spent a lot of time looking at it, but I like to think of thunderstorm asthma events which occur every 5 to 7 years and focus everyone's attention on what is an environmental health emergency as just the tip of the iceberg for seasonal allergic asthma. And so in fact we've got ryegrass pollen related morbidity and seasonal allergic rhinitis burden and asthma risk. But in fact there's a huge annual reliable flux and increase of asthma exacerbations in the springtime, which as allergists we need to be aware of and is related to seasonal allergic rhinitis, but is in addition to. And we can probably do so much more to try and prevent this if we're going to actually remove or reduce the burden of asthma flare-ups in the springtime. So we did a little bit of work about this, looking at thunderstorm asthma in the TASER study, which retrospectively looked at 200 individuals who had presented in the 2016 epidemic. And we followed them prospectively, but also retrospectively, really trying to identify risk factors for seasonal asthma in those who had seasonal allergic rhinitis. We asked people questionnaires, we did physiological data, we did do some biobanking, and we followed with the Aerator app to monitor their symptoms. And what we found was that there were 4 biomarkers that actually were retrospectively associated with asthma exacerbations in the 2016 epidemic. They were eosinophils at 0.2 or more, which, as you know, is well within the normal range, but consistent with other studies of asthma exacerbation. We may hear more of that this afternoon. Ryegrass-specific IgE of 10.1, which is very achievable and able to be done in specialists, but also in general practice. And if this plays out, it could be a really important biomarker. Exhaled nitric oxide, probably not so much used in this group, and lung function that was lower than on the lowish end, but still within 1 standard deviation of the normal. So abnormal lung function was clearly important. So we got some idea of some biomarkers that might be used to better predict asthma risk in this group and therefore allow you to target allergen immunotherapy or other preventive treatments for people that might be most at risk. I'd like to highlight in the TASER study the severity of rhinitis on a number of scoring, but particularly SNOT-22 and others did not associate with the risk for asthma. And this was corroborated by Mark Hughes' paper, which he published in Allergy from the 2016 event, which also showed that the severity of rhinitis did not correlate in any way with those who were admitted to hospital, presumably as an index of severity for their allergic respiratory disease. So we can't rely on the severity of rhinitis to predict asthma risk, and I think that's really important. So what can we do about people to prevent asthma risk in the springtime and also seasonal allergic rhinitis? Can we actually do anything about it? This data is also from the 2016 epidemic and came from Robin O'Hare and Mark Hughes' group at the Alfred Hospital in Melbourne. And what they did, they had been running a trial of sublingual immunotherapy with oral air grass pollen tablets over 3 years up to 2015. And they then completed treatment and were observing them in 2016. They had a convenient sample which they were observing. They were not randomised over this time to look at the consistency of the biomarkers they were looking for as part of this study, which they've subsequently published. But the important thing was that those who had the standard pharmacotherapy had a substantial proportion suffered from symptoms of asthma in the hay fever, in the thunderstorm asthma event of 2016. 11 out of the 17, whereas those who underwent immunotherapy, only 5 required treatment and 12 were asymptomatic. In other words, it appeared that oral air immunotherapy was protective against asthma in the terrific provocation of a thunderstorm asthma event. So where does this leave us? As allergist, I'm very conscious that allergy should be a treatable trait of airways disease and yet is frequently ignored by our respiratory colleagues. And yet I know in this room are the people who can actually start to implement treating asthma and rhinitis as a treatable trait and seeking remission from that as a substantial part of people's respiratory disease burden. So I've already said to you from the TASAR study, we have a ryegrass-specific IgE threshold, albeit retrospective, and I'm sure someone will come and tell me that again. Having said that, let's look at the allergen components that might be important to seasonal allergic asthma and rhinitis. And in particular, we know that the group 1 allergens, which are present in the temperate grass pollens, are also present in the subtropical grass pollens. And LOL-P1 is the ryegrass pollen, but the homologies exist with timothy and the other temperate grasses. What's particularly important, though, is the group 5 allergens, which are present on the starch granules inside the pollen grain. And just to quickly remind you, we think thunderstorm asthma happens because pollen grains are about 20 microns, and you will know physiologically those particles of that size will not get below the larynx. Our upper airway is generally a very effective filter for something as large as 20 microns. However, in the setting of the rapid humidity and environmental conditions of a thunderstorm, these grass pollen grains will burst and enable sub-pollen fragments to be released, which are 2.5 microns. And these are well respirable to the lower respiratory tract, which perhaps explains why so many people, at least a third, if not more, in some of the epidemics who present with thunderstorm asthma, don't know they have asthma. And maybe they don't really, because they don't normally breathe those particles to the lower airway. And so in the weather conditions of a thunderstorm, the people are particularly exposed to the group 5 antigens on the subpollen fragments. So again, Robin O'Hare's group did some work looking at in those who had suffered from from epidemic thunderstorm asthma and those who didn't, and looked at their in vitro sensitisation to the group 1 allergens and showed, as you'd expect, that was somewhat reasonably high in the group that actually looked at whole grass pollen, ryegrass pollen. They also looked at the group 1 allergens, and you can see here that in those who suffered, there was no difference between those who suffered from thunderstorm asthma and those who didn't, even though they were all atopic. And in the group 5 allergens, there was a similar increase. In other words, it was the group 5 sensitivity that was relevant to preventing asthma or that was relevant to seeing the epidemic thunderstorm asthma, not the group 1 sensitivity. Is it important? Well, it's interesting that our TASAR data shows a similar thing, and Janet Davies has done some lovely work looking at ryegrass-specific IgE to the group 5 allergens and showing that in the TASAR data as well, sensitisation to the group 5 allergens, but not the group 1 allergens, was associated with thunderstorm asthma risk. And we're looking prospectively to see how this might be used as a biomarker of risk that might also allow us to better target treatment, to personalise treatment for those with respiratory allergies, for those who can undergo immunotherapy. The similar argument might be made for house dust mite immunotherapy, where it has been noted that the sensitisation, there's three major allergens of dust mite, 1, 2 and 23, which has particularly been linked with asthma. And you can see that asthma risk is particularly associated with DER23 sensitisation, and it's prevalent in about 5%, 1 in 20 of house dust individuals who are actually monosensitised to DER23. How is this important? Well, if you look at asthma symptoms with biomarkers of an asthma allergen immunotherapy, it's fairly easy with allergoid skit, you do get reduction in DERP1 reactivity and DERP2, but DERP3 sensitivity is unchanged over the course of immunotherapy. By contrast, whole allergen immunotherapy with native house dust mite shows significant responses to DERP23, which is such an important biomarker for allergic asthma in relation to dust mite. And so it is, I think, important that we consider whether these allergens are an important predictor and allowing us to recommend allergen component sensitisation might be an important marker of risk that we can use to target individuals with allergic disease and better design our therapy. So this is just some, again, data from Robin O'Hare's group looking at the Cytobas assay, which is a multiplex assay for allergen component analysis. And I'm just saying this could be the future, that we actually look at basophil activation to tetramers, which are conjugated with specific allergens or allergen components that might allow us to have a much better idea of allergic risk. And I think this is on the horizon and may well give us a better idea of what our patients are allergic to. But in the meantime, we probably should be considering the repertoire of sensitisation in order to target allergen immunotherapy appropriately and make sure we get maximum benefit for what is for the individual a substantial burden of undertaking allergen immunotherapy, especially in an environment where it's not subsidised by the government. So finally, I mentioned to you, this is a schematic of the treatable traits that are associated with asthma and COPD, which respiratory physicians focus on. And I just want to point out that allergy is not there. And I think we need to be pretty careful or assertive in promoting that, as promoting allergy as a treatable trait of respiratory disease, because we can make a difference to so many people who suffer. I also want to promote that I know some of you will say, well, TASAR is retrospective, so what does it matter? But we are currently recruiting for the CARISTA study, which is prospectively following individuals for 2 years with allergic rhinitis and looking at their prospective asthma symptoms, hoping really to validate a biomarker for asthma risk in the springtime. And we think this will be something that we can really then build our practice on to help individuals with allergic rhinitis and asthma. So just to summarise the points of my talk, so remission is a focus of asthma and allergy care, and we need to lift our sights to look for remission, not just for ongoing treatment. And allergen immunotherapy offers that promise, with remission being demonstrated, and early remission even for house dust mite. Biomarker studies raise the prospect of us being able to target this treatment better and to use optimal selection of individuals and also agents to get the best effects we can. And I can't leave without thanking all my colleagues, and particularly Rachel Tam, who's worked so hard on TASAR and CARISTA, and looking forward to working with those people. So I'll hand over. Thank you.
Thanks, Jo. We'll ask questions at the end of Kwok's talk here. Put them in the app. I can see a couple coming through. So Dr. Kwok Yang is a respiratory and sleep medicine specialist at the Woolcock Institute in Sydney, having a deep understanding and severe expertise in severe asthma and allergic disease. He's my kind of guy because he's a clinician that's been around for a long time and therefore gives us the whiskey product. Do it time and time again, and you kind of get what you should do, what you shouldn't do. Plus, I read you're proficient in many languages, including Mandarin and Cantonese. So without further ado, Kwok.
Thank you, Sam, for that introduction. I want to make one fact clear. I'm just a simple clinician that's been around for a long time. I belong to the dinosaur club already. So without much ado, my job is to share with you my experience introducing or engaging our patients to immunotherapy, because as you heard the previous speaker demonstrate to us all the facts behind that, and now what was commonly known as the one airway system is important to control the upper airways as a reflection of how much better we can to control the lower airway problem. So this time, declaration, and I'll refer you to a publication last year that a group of authors, and you can see my name down underneath. So it's about how you partner with the patients and the future of the management of allergic rhinitis. So let me make a little sort of statement and said that we try to acknowledge the failings of our approach to the management of allergic rhinitis to date. The current management of allergic rhinitis, there is a kind of little, if you like, discordance between what the patient wants and what we try to impress upon our patients. In other words, so far, most of us that only sort of deliver things that will make them better, but we haven't discussed, at least in some length, about what is the future. So simply, I often talk to my patients that, look, it's fortunate or unfortunate you have this allergy gene. I can't change your gene. And the treatment you use, like intranasal steroids and all that, they're very good in protection. But as long as you used it, you're good. You don't use it, then you're not good. So you have a choice. You're going to use the intranasal steroids for the end of your, for the rest of your life, or you move somewhere like Antarctica, there's no allergens there, or you think about immunotherapy, which has been around since 1911. When I said that, I said, wow, that's more than 100 years old. Yes, that's right. And if some treatment that exists more than 100 years and the basic principles still the same, it must have told us something that must be working. So how are you, or how have I been trying to engage the patients to that? So you're partnering with the patients, and you tell them about the evidence and the guidelines, and also you respect your patients' values and informed preferences of the world. It's a free country. You can choose whatever way you want. So there are 4 elements for sharing the decision-making. Foster the choice awareness. I told them that there's no right answer or no wrong answer. If you want to say, okay, doc, the spray is fantastic, I'm happy, so be it. They're quite safe. But on the other hand, if you say, look, I'm fed up with this, and that's their other choice. So you discuss the relevant options, addressing the benefits versus the risks, and discuss patients' values and preferences, and then you make the final decision. So it's a kind of, if you like, a contract between you and the patients, and you optimal the treatment decisions. So achieving remission, informing an optimal allergen immunotherapy choice, what does the patient hope or expect to achieve? First few months, rapid symptom improvements. Wow, fantastic, I can sleep better now. I wake up without a foggy head and so forth. Reduce and discontinue short-acting medications. Okay, oral antihistamines, intranasal corticosteroids, potential benefit for the lower respiratory symptoms, especially the patient has comorbidity like asthma, and a long-term solution and a lasting protection. So this is a cartoon or diagram showing how this AIT or allergen immunotherapy work. So the efficacy or the sustain of the remission depends on the length of time your immunotherapy and also the actual amount of allergens you given to the patient. So the overall AIT duration, the first phase, and if you can continue on and so forth, then you have a very long sustained remission even after the cessation of your treatment period. Whereas it's not ideal, then you can see from the lower indication that the lower potency of AIT and or poor adherence. So you have to point it out quite early in your introduction to the patient about AIT. So which AIT options give the greatest chance of long-term success, and will the patient remain committed, that is, despite some early side effects? And that's important. And also point out the fact that I mentioned a little while ago, that the efficacy is depending on not only duration, but the total amount of allergens you give. So if you say for the sake of reducing the side effects initially, then you don't have the sort of ideal amount, then obviously you don't have the best efficacy long term. So, are early side effects manageable? Of course they are, at least 95%. So with slit sublingual immunotherapy, there's numbness, itchiness, and even some swelling around the oral cavity, the lips, and so forth. So you reassure them on the sensation in the throat and also the perceived impact on breathing, because if you can't feel for a few minutes, then you think you're not breathing. And that's why, in my experience, that if you give the patient without much detailed explanation what can it be, so after the first 2 or 3 days, they have a sensation, numbness in the throat, they feel as if they cannot breathe. It's often telling the story about going to the dentist when you have the local anesthetic from the dentist for quite some time. You feel that part of your mouth is about 5 times as big. You look at the mirror, no, it's still there, same size. So you have to tell them. Otherwise, they worry. What do? They rush off to the local pharmacy, and the pharmacist says, oh, gee, don't do it again. Next time will be curtains. That's it. You won't hear the patient there again. So it's important to kind of almost preempt the situation so that they know exactly what may expect, and therefore you always leave the number of them to ring if just in case something happened. With SCIT, local injection site reactions too. Therefore, you must make sure if they're asthmatic, they have a good asthma control, and also, if necessary, we pre-treat with bronchodilators. And also, in the pre-treatment, even with slit, you know that they may have this numbness, the itchiness, and it's not uncommon for me to tell patients to pre-treat them with an antihistamine about half an hour before, so that they would alleviate or lessen that suffering, if you like, and that's important. So, you explained the risks versus the benefits. So the other key phases of allergen immunotherapy, the early short-term improvements, if you use medications like Actair, within the first 3 or 4 months, you start to feel the difference in the sense that they start forgetting the short-term treatment. That means the intranasal steroids, because they don't feel the need for it, and that is a good sign. But then comes the so-called phase B, the consolidation, because so very often the patients say, okay, I'm okay now, I don't need anything anymore. Drop everything, and that's bad, because you waste a lot of time and effort. So you have to tell them that you want to have a long-term remission, you have to sustain through this period. And then so that you sort of setting the positive expectation is crucial for motivating the commitment to the full treatment. And there will need to a much better outcome and may go to the long-lasting long-term benefits. Okay, so just the key takeaway messages are: one, setting up the goals of allergen immunotherapy. This can be a definitive solution with potential advantage to the low airway problems. Also, house dust mite and temporary grasses are key drivers of symptoms and disease risks. Registered ART options are highly effective and are considered the first line of treatment, in my viewpoint, okay? And then you also make sure that they can get over the early side effects, which is not uncommon, be proactive and provide reassurance, and continue ART treatment will be rewarded. So, I think I'll leave it at that, and have time for Q&A.
I don't know what you want to do, Joe and Kwok. Do you want to just sit here, and then it's probably easier. Thanks for the questions online. I'm going to just do chair prerogative first. And I guess to you, Joe, first. So if you had the choice of having some grasses in your skin test kit, what grasses would you choose?
Yep.
And then if you're going to now give immunotherapy to grass to a patient, are you going to just base it on the sensitisation pattern that you see, or should we just be doing ryegrass immunotherapy given what you've just presented?
So I did go through a phase. So I do the 5 grasses that are in oral air because I'm just curious. And I also do Bermuda, Johnson and Bahia because we've had, I just like to know because it doesn't matter how many you do really. But I'm really looking to treat the ryegrass, the temperate grasses, and that's why I do them. I mean, often vernal and coxswain have quite a big reaction by comparison. I don't look to ever now put Bermuda in, even if the patient's sensitised. I do ask patients, do you get a lot of symptoms in January, February? And there are some that do. It doesn't seem to correlate that much with their sensitisation. I don't know what I'm treating at that point. And I guess I'm keen. I do use quite a bit of sublingual oral air because it's easy and it's reliable, and I've got a reliable supply, which is a good. I find that useful. I don't use Timothy. I test for Timothy, and obviously it's in oral air, but I think that has got a different group 5 allergen than rye, so I'm conscious of that.
So you're just sort of copying what oral air has onto your skid immunotherapy, basically. It's a question that's been asked about the ryegrass, specifically high ryegrass specific IG seems to be a predictor of thunderstorm asthma. We see, obviously, children who don't like a blood test. So I think the question is there a skin test size that predicts the same thing that you just saw with the specific IG? Yeah,
you're the second person who's asked me that in a month, and we haven't looked, but we can. Okay. We didn't see it when we just did positive or negative, but we're now looking at sizes. We've got it, we just haven't looked. I'll look forward to doing it.
This is kind of to both of you, and I apologise if I'm reading this question wrong, but is it safe to start desensitisation in those with severe asthma? And if not, which immunobiological therapy helps to increase that safety? So you've got someone with terrible asthma, either or, both.
So I think convention is that you should have FEV1 80% or more predicted before you start immunotherapy, and I usually have them on a preventer because generally speaking people with milder asthma should have normal lung function, and we want to try and get to normal lung function if we can. With regard to biologics, if people have allergic disease, I think there's 2 biologics that are indicated, omalizumab and dupilumab for those. And I may, if they have severe asthma and they qualify, then I may put them on that. Jean has now said they could still have allergen immunotherapy on top of it, and obviously that may be protective. But I don't know what you do, Kwok.
Very same, was the same thing that one exception is that people with quite severe asthma for a long time, even with the biologics, their FEV1 never reached 80% predicted. So it might be wrong, but so far I've actually started immunotherapy on patients actually quite low, but they're quite stable, quite steady, and make sure they do all the things, including inhaled steroids, as normal things, and if need be, either pre-treatment with antihistamines as well as a bronchodilator for that matter, on top of the normal maintenance medication.
Yep, I quite agree. We've, I guess, both seen people with awful lung function who have terrible upper respiratory disease particularly, and possibly some lower airway problems, but I'm very cautious with them and try and make sure they're as good as they can be. And I think the luxury of having biologics, if they're really unstable, could turn them into someone more stable and whom that is
correct
to do.
More questions coming through. So, in your opinion, both of you, what happens in a polysensitized patient who's got perennial symptoms? Would you just go for the perennial symptoms, fix that first, and then see how you go? Or do you just go, well, you've got both things, let me treat both things?
Good question. It all depends on the, I have to say, you have to customize to each individual. Depends on the occupation, the environment, and all that. And of course, the basic principle is the most dominant allergen, number one. Number two is that in the history taking is another thing that makes you be more alert to other things. For example, if you have positive reactions to dust mite, to grass pollens, and to horsehair, and then you say, well, horsehair, and then you do think. And the examples, of course, they like to ride horses, weekends. That's one thing. The second thing is that if they play a string instrument, the bow of the string instrument is horsehair. So you have to sort of really have a detailed history to determine which allergens you should include or you don't need to include.
Yeah, I like the word you chose, dominant allergen there, and I don't mix allergens, and I think that's because all the evidence I've ever seen for efficacy is in single allergen immunotherapy, and that's why I do that. So I really spend time, like you have said, trying to find what is the important allergen, or what I think is most likely to result in best remission for this people. And to be fair, 98% of the time it's dust mite and grass pollen, and it's a choice between one of those, or indeed both if you really think it's important. And as a horse rider, I'm delighted you chose, and an allergic one at that, I'm delighted you thought about it.
Joe, that's a good question because it's controversial and it's the elephant in the room. So, in terms of native versus allergoid and remission, is there any evidence that allergoid does what native does for remission?
So we should all be looking, I think, for what's best for patients, and I am aware of limited randomised placebo-controlled data on allergoid. I'm aware of one study, but I'm not aware of data in remission for allergoids, and I'm old enough to remember when we had allergoids last century and we stopped using them eventually when something better came in. So I'm conscious that that opportunity is there, and those companies could invest in that, and they need to, I think, if they want us to use them. That's what I think, because otherwise we've got good evidence in native allergens.
Same experience. I yet to see any good publication about the efficacy of allergoid, number one. And number two is being old-fashioned. I still believe, because what you get used to and your sort of result, native is still the way to go, as far as I'm concerned.
Richard Lowe just texted me and he wants to ask a question because he can't type. Go, Richard.
Sorry, Richard.
That's all right.
My reading glasses couldn't. Leading on with the first question, Joe, a lot of your data is Eastern Australian data. For those of us who work in Western Australia and Queensland, I think there's somebody working in the Northern Territory. If you've got a patient polysensitized to rye, Johnson, Barré, and Cooch with symptoms in summer, and you have a choice between an injection that gives predominantly ryegrass versus a rye, Johnson, Barré, and Cooch. I know the rye will work because I know they are sensitized to rye, but is it better for that patient to use a grass mix that's got Rye Johnson, Bahe, and Cooch?
So there is some homology with the group 1 allergens across some of them. I don't know if Janet Davies is in the room, but she can talk to that. Southwestern Australia does have quite a good concentration of temperate grasses and high temperate pollen counts. So I think that risk is very real from the group 5 and 1 allergens for the temperate grasses. So then I guess you're left with the question of how important is the subtropical grasses to symptoms. Now I know perhaps there's old data from the Central Australia that their cooch is really important because they don't have any temperate grass. So I think some places don't have temperate grass, and then you've got to think again. Where you've got a mix, I think there's good evidence to think about it. And I don't think we've got good data to answer the question. But how many you mix with is also important, because it does worry me, because by the time you get to Johnson, that's a very different grass with different allergenicity, whereas at least Bermuda overlaps on the group 1 allergens a bit. So then it becomes more problematic, I think, to make
And
that
pretty
decision.
simple, I guess.
Yeah.
If a patient is allergic to 4 grasses, and I've got an allergen mix that covers 4 grasses, why don't I use the 4 one, and why should I put them on 1? The 1 will work. But simple me, if they're already polysensitized, shouldn't the 4 perhaps give additional benefit? I'm not doing harm. If they've got symptoms in January, February, March.
You're absolutely right. And the counter-argument to that, and I don't know the answer either, Richard, is that the counter-argument might be that allergen immunotherapy is clearly very dose-dependent, because you look at the original data, look at the data with oral, 100 almost doesn't work, the 300, 500 had a lot of side effects, 300 was a sweet spot. It really is that careful. So how well do we know what we're putting in mixes in terms of allergens? To actually know, let alone what comes out at the other end after sitting in a soup for 6 months when no one looks at stability. So that is my concern about mixing things. Now, they say mixing with, say, similar things, like mixing grasses is all right, and mixing dust mite, and we often give a 50-50 mix, that tends not to eat each other up. But I think they're the questions that we don't have answered and we need answered if we really want to be strong in pursuing that strategy. I'd like to see more work on it.
Thank you.
No, Joe, this is your fault because you had it on your slide. So do standard house dust mite mixes, the Skintex mix, contain DERP23?
Yes. I don't know.
Yeah.
That's the answer. We're discussing. I don't know.
I asked ChatGPT because I saw that question. And ChatGPT said it probably has very little because you're using a whole extract of house dust mite. It's in D. terranicius. This is ChatGPT, not me, right? So it actually has very little in your skin test. But then I guess, Joe, you were saying that 5% can just be monosensitized. So is it possible that we're sort of missing some?
We all get those surprise patients you swear are atopic and then their tests are negative.
Other questions? A popular one, are there any contraindications where you wouldn't use immunotherapy in patients? So someone's asking about malignancy, active autoimmune disease, EOE, particularly for SLIT. And do you both specifically worry about some products may not be TGA approved, or immunotherapy is immunotherapy?
That's a very, say, political question in a sense, because there are times when there was shortage of supply, then one didn't have any choice other than stop or use so-called non-registered products. So, of course, when there is available now, one should stick with the TA approved one, and that's my take. I don't know about you, Joe.
I would always favour an approved product. I think it gives us assurances to the quality of the product, and we have more understanding then. And the investment of the companies in actually getting it registered is important, I think, so we actually get more of them. We don't think that matters. So I do think I would go for a registered product for that reason, if I have a choice.
Just one additional comment is that with the registered product, unfortunately, there's a very limited range you can choose from, and I'm referring to so-called, in my collection of patients, there are horse trainers and jockeys and all that. And not surprisingly, apart from grass pollens and all this sort of thing, big reaction to horsehair. So what do? Okay, so you tell the horse trainer, change your occupation now?
Well, that's the same to vets.
That's right, to vets.
Vets with cat allergy, I think.
Yeah, that's right, yes.
Just probably the last question, because I know we've got 2:30 start. Practical one, do you start oral air once the season starts, or do you consider it too high risk? So there'll be some patients who will come to you, it's not June, July anymore, it's August, September. Do you take the risk and say, let's go?
So I increasingly do. I probably would in November, but if they've got 2 months, I'll go. So August I'm pretty happy with. Yeah.
Kwok, yourself?
It all depends how bad are they, and also now don't forget that you have your oral antihistamines, you have your INCS with antihistamine in there, so you can sort of stop them both, even with a higher dose of the intranasal steroid spray. Then you can over that, and then you continue with the oral air.
There's one group I would be really worried about. There are some people that end up coming to hospital or having asthma exacerbations every November. I wouldn't touch them. I would wait till winter. Yep.
I'd like to thank both speakers very much. Well done to both of you. And that wraps. Thanks, guys.